Topic today is the active shooter readiness of health systems as a new patient safety issue. And we're delighted to have great speakers, and I'll go through our usual opening comments regarding making sure that you have your computer volume up to its highest level. And if you were not to be able to hear us properly, then you can click on participants, and the phone icon in the lower left-hand corner of your screen, you can request a direct line. And hopefully you'll have good audio. I'm on slide 5, and I just want to remind those that don't have the slides just yet and have just called in or logged in that you may get the slides by going to www.safetyleaders.org, upper right-hand corner, upcoming events, and click on this webinar, which will take you to the page that is on slide 6, which actually has where we have our speakers, and we'll be posting more information on those pages, on that page and those pages as well on the website. Slide 7 just addresses our social media presence. And on slide 8, our purpose, and our purpose statement is we will measure our success by how we protect and enrich the lives of patients and families and caregivers. And so this is a very appropriate webinar to address the safety and into enriching the lives of our caregivers. And our mission is to save lives, save money, and create value in the communities we serve. I won't go through our disclosure statement, which is on slide 9. And I just am really delighted to have Dr. Greg Botz, Vicki King, both as main speakers today. We're going to cite a paper by Dr. Swensen from the Mayo Clinic regarding some upcoming opportunities and a call to action. And at the end of the webinar, we'll play a short video or short audio by Sharon Rossmark, which is our board brief about governance leaders. And a topic close to all of our hearts is getting more caregivers on the boards of healthcare institutions. We also have Chief William Adcox will be joining us after the formal presentations to react to the content that's presented. And Arlene Salamandra, our longtime patient safety champion and wonderful partner, who is a published author in patient safety, tireless champion to really help us with many topical areas of patient safety and quality. She was a co-author of the chapter in the National Quality Forum, Safe Practices, and also multiple publications. And most importantly, she has a real heart for the areas that can stimulate some of the challenges and problems that we have to face with threat awareness of our caregivers within institutions. So, Arlene, would you please speak to us for 30 seconds to 45 seconds just to kind of set the tone for our webinar today?
Well, first of all, I'd like to thank everyone for being here today for the webinar. We'll be covering 2 important topics that are very important not only to caregivers but for patients. So I'm looking forward to the discussion. Sadly, active shooters is our new reality, and we should all be prepared, especially in a hospital setting. As a patient, I'm glad that this is being addressed today, and hopefully we could all learn something, and this outreach should be brought to patients too, what to do as they're in the healthcare facility. And then the CT imaging for children is especially concerning to me, anyone who has children or grandchildren, and I hope the patients will be informed too to ask questions, and I'm very interested to see where that is right now today. So thank you, Chuck. Back to you.
Great. So I'll cover very briefly a couple of key issues that we've been reporting on over time, and then move to the topic at hand. The first is a call to action to prevent risk to children with computerized tomography. And Dr. Swensen has been a tireless champion on this with a number of folks, including Dr. Duncan and others who you know. The co-authors of the article I have up on slide 14 was an appeal for safe and appropriate imaging of children, led by Dr. Swensen, and you all can recognize a number of the co-authors of this paper, which really was making a call to action to reduce the overuse of CT scans in children, as well as right-sizing the protocols. And we're hopeful, and we were hopeful today to announce something that is the result of this call to action, and we're just waiting for the formal announcement. So in our next webinar, we'll expand on this. But there are some, I think, some great news coming our way regarding that topic. So we'll hold on that for today because of the formal announcement. But we'll be calling on all of you to submit your support to a new national standard, and that's all I can really say today. Now, the second topic that we wanted to bring up to you is the Caregiver Act, or the CARE Act, and this CARE Act requires hospitals to name a family caregiver, recorded in the electronic healthcare record, notify the caregiver if a loved one is to be discharged or home or to another facility, and most importantly, provide explanations and live instruction of the medical tasks that must be undertaken at home. It's now being recognized critical safety issue for readmissions to hospital and great care. AERB has been a terrific champion, and there are a number of papers and reports on this topic. We just wanted to report to you the last webinar that we had on slide 16, the number of states that have already passed this rule or this act, and this was as of January. Our next slide actually shows that Wyoming, Kansas, and Hawaii are now considering it, and most recently Utah has passed it. So we're seeing this continued trend in patient safety and quality, and it's something that we can really address in all care settings, and a terrific result of great lobbying movement on that. Also remind you that this is passed the House of Representatives, and there are a number of things in the press about this which really shall impact us in patient safety and quality, and more topics we'll address on this as well in the months to come. We also wanted to report our January polling regarding a health information community of practice, which we were prepared to launch. However, with the abrupt announcement of the discontinuation, either in part or in whole, of the meaningful use requirements, which has driven this trillion-dollar industry in electronic healthcare records, and not knowing exactly what best practices would be best to adopt, we ask you, do you agree with a delay in the start of that community of practice, which would have been a series of 4 to 6 webinars specifically on best practices you could adopt to make HIT safer. And we're planning to wait until the experts that we've tapped can really give us the best practices that are most likely to align with what you'll be required to do. So now on to the setup for this next topic, which is the issue regarding this active shooter issue, and really more broadly, which Vicki King will be covering, is threat management and having a really good program to manage potential threats, and to us in healthcare, not only to our patients, but also our caregivers. This weekend, there was a Diane Sawyer special, and she covered, and it's on the web. I watched it. It's terrific. It really gives the backstory to what happened with the Columbine issue, and it's the interview of the mother and the book that is written by Sue Klebold, whose son was one of the active shooters. She addresses things that are just heartrending to us, as all of us as parents, as we think about our children. And as you see some of the data that was presented over the weekend, it's shocking to find that these are not likely candidates. So what are the numbers? And I'll just cover this, Vicki, very quickly, and then we'll go through with Dr. Botz and Vicki's presentations. But just some of the issues that are really key, the numbers are there are 50 school mass murders attempted since Columbine, 141 people killed, 73% had no arrest record. 96% were male, and 17 were children 15 or younger, which was just such a shock. 81%, someone had information about the planning of the shooting, and this, Vicki will talk about, preparedness and readiness. And as we think of our healthcare institutions, which are increasingly being hit, and that's why we're covering this today and asking ourselves, is this right in the wheelhouse of patient safety and quality officers, or is this a combined initiative with and multi-disciplinary approach, and what should we in patient safety be focused on? 68% got guns from families or friends. 65 of the school shooters referenced Columbine. So they actually referenced that as part of the reason. Shootings of any kind at a school since Columbine are 270, and there are 1 shootings per week at a school or a college. And Vicki's going to talk about healthcare institutions and the numbers there. So it's really with great pleasure that I'm going to introduce our 2 speakers, and Dr. Botz, who is a professor of critical care at MD Anderson, and I'm here in Houston at Texas Medical Center, and honored to be working with Texas Medical Center on multiple topics. However, Greg, because of his commitments, was pre-recorded his session, and Vicki is here live with us as well as the recorded session. Greg, as you all know, he's been a speaker before with us at TMIT, is a professor of the Department of Critical Care at the UT MD Anderson Cancer Institute. He is a real champion for patient safety. He leads simulation there. He completed a medical simulation fellowship with Dr. Gaba, and he's board certified in anesthesiology and critical care. Also of note is that he has an adjunct appointment at Stanford, and when he takes his time off, he rides helicopters, training the nurses and the residents in critical care. So this is someone who is a real champion for patient safety and quality, and has really illuminated things for our team regarding the critical things that caregivers need to learn that they don't already know. If an active shooter were to hit your hospital, there are many things that we can do to save lives, and many things that haven't been public regarding hospitals and healthcare institutions, as well as the schools, and the real difference of things that need to be covered. We're really honored to have Vicki King, who has a 30-year career, and she served 27 years with the Houston Police Department, rising to the rank of assistant chief and earning a master's degree in criminal justice. She was chief of detectives, tactical support commander, and director of forensic services. Oversaw some of the HPD's most high-profile cases: serial homicides, corruption, domestic violence, sexual assault. She's an adjunct professor for the University of Houston system, and has had numerous events of recognition for her great work. And we've been working with her, with Dr. Botz, regarding the potential for Houston developing a program that could be offered nationally to help healthcare, specifically healthcare and schools, but specifically healthcare organizations, with this challenging and new area that's just exploding. With that introduction of both of them, I'll ask Kyle to roll tape on Dr. Botz, and we'll hear from both of them, and then we'll have an interactive dialogue, and then we'll have our reactor panel. Kyle, please roll it.
It's a pleasure to be with you today on this webinar to speak about active shooter readiness of healthcare systems. In previous webinars, I've shown this slide and described how hospitals are dangerous places. That shouldn't be a surprise to this audience. We often focus on patient safety by looking at the issues brought up by the Institute of Medicine regarding the excess medical injuries or accidents that can occur in our healthcare system. And we're well aware of the patient safety risks associated with the system that we work in. We're really concentrating on the care that's delivered between healthcare providers in hospitals and the significant risks to patients of the way that we deliver care. But today I'd like to change focus. I'd like to move perhaps to a higher level and talk about patient and caregiver safety issues. In other words, the institutions and communities within which we work. It's no surprise that there is increasing stress in our workplace. We all know that delivering health care is a very stressful job and more demanding of our time and attention. We're very worried about causing harm to patients or allowing things to reach our patients that would lead to adverse events. In this infographic, looking at stress at work for an IT administrator, we can see that as many as 2/3 of IT administrators report that there is significant stress in their job. And the important thing to consider is on the top right, seeing that these stressors impact our personal life. As an extension of that stress in the workplace, we are seeing increased violence in the workplace. And this infographic from a Canadian study shows that from 1999 to 2008, there was a significant increase in workplace violence. Now, not all of this is in the news. Not all of this is readily discussed by people, but I think it's really important to understand that healthcare is a particular environment. Workplace violence is a significant risk. We can see that approximately 33% of healthcare is involved in workplace violence events. In fact, the top 4 most common locations for work violence include hospitals. The most extreme form of workplace violence, I think, is an active shooter event. And we've seen examples in the news recently of events where someone takes a weapon to a workplace and causes significant injury and death on the people in the workplace. So what's the problem? Well, the Department of Justice and the Federal Bureau of Investigation did a study recently looking at active shooter incidents in the United States between 2000 and 2013. And their findings in a snapshot in this infographic show that there have been some 160 events in the United States during that time, leading to more than 1,000 casualties. About half of them were fatal accidents or incidents, and about half were significant casualties with significant wounds. I think a very concerning statistic is that over the first half of this period of time, there were about 6.4 incidents per year. But over the last half of that period of time, there were almost triple the number of events per year. Looking more closely at the incidents annually, you can see in this next graph that the number of events is increasing significantly over time. And in the next graphic, you can see that the number of casualties is increasing as well. Well, we can identify the problem that we have an increasing number of active shooter events in our communities, both in our schools and public places, but also increasingly in our healthcare facilities. So what's the solution? I think there are several approaches that we need to consider in order to make our workplaces safe for our patients and our caregivers. The first will be discussed in the next presentation by Inspector King regarding a threat management approach to reducing the risk and identifying vulnerabilities to these threats. And the other action that we can use as a solution is active shooter training our staff and our facilities on how to react, how to behave when an event like this occurs, because there's such a high possibility for harm and injury to our workforce. The program that is endorsed by most of the federal agencies and our law enforcement agencies is the run, hide, and fight approach. And there are a number of different groups that are providing this sort of training. And I think it's important for us to integrate this into our workflow and our workplace, just like we do many other best practices to try to make our healthcare environment healthy and safe for everyone. But one size doesn't fit all in this training, and I think it's important to recognize that healthcare may be slightly different than some of the other environments where active shooter events might take place. And in this manuscript from FEMA, which incorporates active shooter incident planning into healthcare facility operation plans, there are a number of reasons why healthcare settings are different when these events take place. We're going to explore that a little bit more. It's no surprise that there's a lot of stress involved in the care that we deliver, both on the part of patients and families and caregivers, and that might be a trigger for people to bring an active shooter event or a workplace violence event into the healthcare setting. We often see patients with a clinical decline that is very stressful on patients and families. We deliver bad news at times, which is very difficult for some people to cope with. And with the advent of medical errors, disclosure of these medical errors can often lead to anxiety or anger that could lead to a violent outcome. As well, most of our healthcare communities involve large number of caregivers from a variety of different disciplines, and many of them may have domestic violence issues, could be brought to the workplace where a violent action could take place. Hospitals are very much a high concentration of vulnerable patients. So these ill and injured patients can't care for themselves necessarily and are completely dependent on the healthcare providers for their needs. In our hospitals, because of the way we care for patients in high acuity units, there may be complex evacuation issues that make it difficult to move patients quickly away from an area where a violent event is taking place. Some of our patients are on life support and require the use of medical gases or other interventions to provide care while they're in the hospital. There are issues with emergency power that may influence the way that law enforcement interacts with the event in a hospital setting. For instance, one of the usual standing operating procedures for one of these events would be to close off all communication, cut off power to try to deprive the person who's involved in this event from gaining access to information about the response. Well, we can't have those things in hospitals because if you turn off all the power to our pumps and the power to our ventilators and such devices would lead to significant harm to our patients. And I think a more important thing is that we understand that as caregivers, we don't want to abandon our patients. We won't easily turn and evacuate away and leave our patients even more vulnerable to a very dangerous event. If you think about it, most of us, when we hear about a significant event going on in the hospital, rush towards that to try to help. But in this circumstance where there's an act of violence taking place, we want people to move away from that event as quickly as possible. There have been a number of events that have sort of highlighted this difference between healthcare and other parts of the community. There was an active shooter event at the Johns Hopkins Hospital in 2010 where a patient's son was given bad news by a physician outside the patient's room, and this led to him becoming enraged. He pulled a pistol out and shot the doctor and then went into the room and barricaded himself. The end result was that he shot his mother and then committed suicide. This was perhaps one of the more high-profile events that led us to focus on healthcare responses to active shooter events or workplace violence. There have been a number of conferences and a number of manuscripts that have come out of that event that speak to how hospitals can be prepared and how they can operate when these active shooter events take place. So my question to you is, how prepared are you? Let's self-reflect on how we as healthcare institutions are ready to deal with an event if it were to take place in our hospital today. If someone came in the doors with a weapon and started indiscriminately shooting at people, there might be a number of casualties in their path. The response from law enforcement may be quick. They've done a lot to train on how to move towards isolating and neutralizing the threat. The local resources might be few, but they will do their best to identify where the threat is and go to neutralize it. But the large-scale response by law enforcement is not going to be very quick. And so we have to be prepared to run, hide, or fight to be able to protect ourselves, our patients, and our colleagues from these events. And as you know, my focus has been on performance gaps in healthcare, especially in patient safety. So if we honestly evaluate our preparedness, I think we know that there is often a gap between how we think we behave and perform and how we actually behave and perform. If you don't look at that performance gap, you may be lulled into a sense of security that you will react and behave and perform optimally when one of these events takes place. We spend a lot of time and resources for responding to emergencies in hospitals. We do a number of life support training drills to deal with medical emergencies that can take place in our patients and in our staff. But hospital active shooter training is another focus that we need to integrate into our hospital operation plans because we know there's increasing vulnerability, and it's not a matter of if it's going to happen in our facilities, it's a matter of when. So the question is, are you prepared for an active shooter event at your hospital? Have you conducted an assessment of your response plan? Do you have an idea of how you would behave as an institution if one of these events took place inside your doors? Have you identified evacuation routes that work for your personnel and for your visitors? If there isn't an easy evacuation route, have you identified and practiced a safe hiding place to reduce the likelihood of being injured by the active shooter by reducing the likelihood that they will see you in their path? Do you have an effective access control system? I know in our hospital we have many, many buildings with many doors that open, and so access into the building is something that's very difficult. If you don't have an access control program, especially at night and on weekends when staffing is lower, the risk vulnerability increases for people to gain access to the facility to undertake these events. How about maintaining the communication? I think we've learned best practices from some of the events that have taken place recently, like the Naval Hospital event in San Diego several weeks ago. Their use of social media to get information to all of their personnel was admirable and a gold standard for how to ensure that effective communication takes place. I think an example of communication I saw was a Twitter notice that went out saying that the child center had been secured and all the kids were accounted for and they were safe. That obviously takes a great deal of apprehension and worry away from parents who would naturally want to move towards the care center to get their kids, perhaps even increasing the risk of for themselves in doing so. An imperative is to train staff to work with law enforcement. If your institution isn't plugged in with your local law enforcement to have discussions and perhaps practices on how to deal with these situations, you're missing an opportunity. I think another thing we need to concentrate on is using plain speak. In many hospitals, they have codes for different things: code black, code blue, code red, code silver. I think if we move away from those sort of designations and say things like, there is an active shooter on the 3rd floor of this building, move away, that will be a key indicator that people should evacuate, not rush towards the emergency. Keep it simple, take action, and practice. The more that you practice, the more likely you are to be in a state of readiness when one of these events were to take place. And again, stay informed. And now I'd like to turn over to Inspector V. King, who will speak to us about another aspect of the active shooter spectrum.
So we're delighted to have Vicki King now with her session, and then we'll have our interactive dialogue to follow.
Pleasure to be here with you today, and we want to share a little information that we have regarding prevention. Every physician, every nurse, every medical care professional has prevention as their number one focal point, and what we would like to do to prevent an active shooter from ever occurring. And one of the mainstays, in fact, the standard of care for preventing violence on your campus, in your hospital, and in your workplace is a very robust threat management program. And I just want to piggyback on what Dr. Botz just explained. When we see active shooters on the news, we see these catastrophic events with multiple casualties, but it happens more often than you may think. In 2014, we looked at hospital shootings, and we saw that there were 55 different hospitals who had a shooting event occur on their campus. 3 of those, Northwest Texas Hospital, Cedar Park Regional Hospital, and Ben Taub General Hospital, occurred here in Texas. Ben Taub is very close to us, and there was some leakage as we'll talk in a few minutes, regarding that event where a co-worker of a pharmacist that he had become romantic enamored with. And so there were some opportunities there to have a good intervention, and that one strikes very close to home. Of those 55 different hospital events, 39 people were killed and 18 were wounded. When we look at violence against hospital nurses who have the most interaction with patients and visitors, a May 2014 survey of nurses found that 76% of all nurses experienced some form of workplace violence. Now, most of this was verbal abuse by patients or visitors, but there was physical abuse reported by almost 30% with regard to the patients. When we look at partner violence, that is something with a high employee count. We see that intimate partner violence will seep into the workplace. There was a 2014 study of education, healthcare, and transportation employees who found that over 18% of those who are being currently victimized by an intimate partner experience some of that violence on their work premises. Now, many people push away from that and do not want to become involved in one's personal life off campus. But when we look at the same study, they said that victims who disclosed reported feeling more hopeful about their future, safer, more supported, and better able to concentrate. It also helped push violence off of the work premises. And again, prevention is the cornerstone of what we're trying to advocate in this webinar. Now, when we look back at the Virginia Tech tragedy, which was probably the seminal incident that changed how we started to look and how we started to attack these active shooter events, there was a joint commission report to the president, and this commission report was put forward by the Department of Education, the Department of Health and Human Services, and the Department of Justice. And the key findings here were that critical information sharing faces substantial obstacles. And that occurred in 2007, and it's still occurring today. We still have silos of information, this reluctance to report, worries about FERPA, and privacy rights of visitors and patients and employees. But when violence occurs, there are always exceptions to those statutes. We also are concerned, in the presidential finding, they talked about accurate and complete information on individuals prohibited from possessing firearms is an essential way to keep guns out of the wrong hands. In Texas, we have a right to carry movement that has progressed to open carry, campus carry on college campuses, and there are some medical facilities that may have areas where concealed carry may be permissible. So firearms are becoming more prevalent in our workspaces rather than less. Also, improved awareness and communication are keys to prevention. We can't say this enough. Awareness and communication. And as part of the active shooter training, we talk about how to prevent these things, how to report behaviors of concern, behaviors that may escalate into a violent event. The sooner that we know about those and we apply some intervention strategy, the more successful we can be in preventing these events. So it's critical to get people with mental illness the services they need, but it's also, this was a significant finding, where we know what to do, we have to be doing it. And we know that people with mental illness need to have successful treatment, that they need to be in treatment. They need to have their activities monitored. We know that intimate partner violence, that when an intimate partner leaves her abusive, and I use her, it could be of him as well, but majority are women, when they leave that abusive environment, their threat of being seriously injured or killed escalates. It doesn't get safer, it gets more dangerous when that occurs. And when the intimate partner cannot acquire the victim out in the real world, where do they go? They go where they work. So it's important to be engaged. So threat management teams have become the standard of care for preventing violence on your campus and in your workplace. So this is all part of an organizational health model. Threat management will sustain the health and campus safety with the goal of preventing violence through early identification and swift application of intervention strategies. What we want to do is intercede early. This is a prevention model, not a prosecution model. And the police departments on our campus are engaged early and become the information gatherers. They start helping push gather the pieces. Let me emphasize, just because you have your security detail in your hospital or your police department engaged in these types of events does not mean that their focal point is to prosecute individuals. The idea, the goal here is to prevent violence from ever occurring. Now, there are some high-threat incidences that require immediate suicidal or homicidal ideation. Stalking or harassment, these have been shown to escalate if they are left unchecked, and they can escalate into a workplace violence event. Domestic violence will the cycle of violence, it may ebb and flow, but the cycle of violence is a proven pattern of escalation, and these kinds of events can be detrimental to the workplace, especially when the person who is our suspect is intent on getting revenge or controlling that individual, and they travel to the workplace. Assaultive or threatening behavior. Patients, family members, as Dr. Botz talked about, when bad news and people are confronted with grief, sometimes unimaginable grief, that can turn to rage very, very quickly. So if there is a pattern of assaultive or threatening behavior before a critical event occurs, that's the time for an intervention strategy, not to wait until it escalates. And then, of course, dating violence and sexual assault are areas of primary concern for law enforcement. So our threats extend well beyond mental illness, and many times in our active shooter events we focus on those who are mentally ill. But there are different types of workplace violence that can escalate into an active shooter event. Now, we have a typology that we categorize these events into. Criminal intent type 1 is where someone completely unassociated with the hospital comes in and is intent on doing harm in the workplace. We see those a lot in our emergency departments where criminal elements try to infiltrate the very dynamic hospital experience and take advantage. They are most vulnerable of our population, either for theft or drug seeking. So we've had those events here, and linkage between and among our hospitals are extremely important, because if someone is successful at exploiting our very vulnerable population in one area and they are displaced through intervention methods at that hospital, then they are going to move and displace that criminal behavior into another environment, another hospital environment. We also have customer, client, or student, or patient is our second typology. When we have our patients here at MD Anderson, we had a patient who was nearing the end of life. The patient had a brain tumor, was experiencing a great deal of pain, and unfortunately became delusional. He had a sitter with him who was protecting him against a fall risk, and his delusions manifested itself so much. He took her hostage with a knife and held the knife to her throat. And through the brave efforts of officers who responded to the scene, and even though they could have engaged that patient with deadly force, they were able to work through the psychosis, work through the delusion, and talk the patient down. That's part of the training that is so critical. You never know when you may be confronted in that run, hide, fight get cornered and you're able to maybe de-escalate a situation. And it doesn't have to be an active shooter. De-escalation techniques are a critical part of our ability to keep these events and to mitigate the carnage and talk people down. We also have worker on worker. That's probably the most commonly reported type of workplace violence that occurs, everything from threats to actual physical violence. But probably the most dangerous is that type 4, the personal relationship that we've talked about spilling over into the workplace. We also, here at MD Anderson, we track a fifth typology, suicidal ideation. And we all know that suicidal ideation can turn on a dime to homicidal ideation. So getting help for people is just the right thing to do. And so we talk about those situations. But we do have some challenges going forward. Our case referrals are increasing. That's a good thing. That means communication is increasing. But the problem is that the numbers of reported cases still don't reflect our population. James Cailwood, an expert in the field of workplace violence, predicts that between 1 to 1.5% of the workforce is experiencing some form of workplace violence. And those incidents need to be reported, because if we don't know about an event, we can't respond to it. And we talk about the crisis continuum. In a threat situation, not resolve themselves. Much like cancer, they're going to become more severe and more frequent and multiply over time. So what we would like to do is to look for that inflection point, look for that opportunity where we can have a successful intervention. The earlier we are able to work on a problem, the earlier that we are able to get our multidisciplinary group together and have a team approach to reducing that violence continuum, the sooner that the more successful we can be. On the crisis continuum, left unaddressed, it's going to progress sometimes to a catastrophic outcome. To achieve that positive outcome, the key here is the information gap. We cannot assess or act on what we don't know. So communication and establishing those communication resources, it's not enough to say, to have a campaign that says, see something, say something. Well, see what and say to whom? What we want is, in our active shooter training, as we prepare for these events, to give people the information that they need so that they can say something early, understand what the behaviors of concern are, then they know to whom they need to report them to. Their behavioral intervention team, their police department, their security department, even to their supervisor, and move it up the chain of command so that we can have that successful intervention strategy. Here at MD Anderson, we have a prevention-oriented skill set with our officers, and with not just basic policing skills, but more importantly, to become an engaged partner, to understand what institutional risk reduction means, to gain the community trust and establish good community relationships, and contribute to organizational health, and following along with that skill set, that converged skill set, to move further left of boom is what we like to say, to create some additional bandwidth before a catastrophic event should occur, so that hopefully we can either mitigate it or neutralize it. The concept here is that threat management is an institutional endeavor. It is incumbent on the entire community, not just your security force, not just your police force, but it is incumbent on the entire community to keep safe. And we reinforce those skills during our active shooter training. What we want to do is to prevent. So when we look at the core functions of a threat management unit, we look at a centralized reporting, establishing what that is. We want to triage the reports that we get in because most of the time the reports are relatively minor and they're pushed to supervisors to handle, they're pushed to HR, they're pushed to patient advocacy, they're pushed to student counseling, they're pushed to the appropriate resource to have the correct intervention strategy. But we're going to continually assess that threat. We're going to continually assess the risk to the institution. And we're going to access all available resources to to resolve the problem, to get to the root cause of the problem, rather than treating the symptoms as we're wont to do sometimes. If someone is acting and behaving inappropriately, we tiptoe around them. We have a tendency to try and keep them from going off instead of addressing the root cause. What is the point of frustration, and seeing what that is? We want to perform, empower through interventions. We want to coordinate. We want to have a coordinated follow-up. We want to continually monitor these cases. We assess long-term success, and we look at the outcomes of having a safer workplace. But the most important thing that we can do, the critical element, is to educate the community, because an educated community knows how to respond, knows where to respond, and can provide the best patient safety and employee health.
Great. Thank you very, very much, Vicki. Kyle, what we'd like to do is put up the polling questions, and then we have a great interactive session between Dr. Botz and Vicki, and then we have Vicki live also with Chief Adcox. So what I'd like to do is, Kyle, have you put up the questions for polling. This is really important to us because we're considering putting a program together where there could be off-site training for teams, say here at the Texas Medical Center, as well as a community of practice with monthly webinars and best practices. And we'd like to know from you as an audience, from what you've heard, and you'll hear more, but would you or your organization like more on threat management best practices? And you'll hear a little bit more from Vicki and from Greg regarding some of what those practices will be, but you got a hint of them from Greg's presentation. Things like learning how to create a medical lane, working with your first responders, working with the local law enforcement to really have an integrated and a multidisciplinary team approach. The second question is, would you like a community of practice with monthly webinars on threat management, including, but not limited to, including the active shooter readiness? So this would be broader threat management issues, many of which Vicki had talked about. So the first question was, would you like more on best practices? The second question is, would you like a community of practice, something that you could participate in as a member? One of the issues that we'll talk a little bit more about is there are certain best practices, and there are certain things we know about preventing the loss of life that we don't want public. We don't want to inform people considering such catastrophic events and leading them to know the vulnerabilities. So if we had a closed community of practice, so we knew everybody that was in the practice, many of these best insights could be shared to potentially save the lives of children, your patients, and your caregivers. The third question is, would your organization be interested in off-site threat management simulation for teams? What if a simulated hospital could be provided with law enforcement trainers, clinical trainers, mass casualty trainers, so that teams could come off-site for a few days and actually have recreated for them and participate in real immersion simulation what they would need to train for to know how to act in terms of these events. And then the fourth question is, would you like a train-the-trainer program? This is different, but both could be offered, where you could send a trainer or some trainers off-site to get trained to come back to your organization so that immersion simulation could be undertaken so we could go to scale much faster and better. So these are separate questions, and on a scale of 1 to 10, 10 being your most strongly, what you most strongly agree with, and 1 very strongly disagree with, we'd love to hear from you regarding these last 2 questions. Would your organization be interested in off-site threat management simulation for teams? That means sending a team somewhere like Houston or other places where they could really work together as a team, immersion simulation, and really be able to come back with those best practices having been practiced. And then the last question, would you like a train the trainer program so perhaps you could send trainers to be involved so that it wouldn't be as costly, and then they could do things online and that kind of thing. And the final 2 free text questions are, what training topics would you like in a threat management program, the likes of which you heard Vicki discuss here. And then the last question is, what are the challenges or issues to quality or safety leaders taking on threat management? We know that many of our audience are fully loaded on their patient safety issues regarding medication management, misdiagnosis, EHR, accidents. And if you could just address for us some of the pain points that you anticipate if you don't believe it's in your wheelhouse, and just help us through that, because risk management should be involved, and security should be involved, and operations needs to be involved, and we just want to open the door for you to comment on some of the challenges that you might face there. And so now what I'd like to do is roll tape in the interactive discussion with Dr. Botz and Vicki, and then we'll have Vicki and Chief Adcox live, along with Arlene Salamandra. So go ahead, Kyle, and roll tape of the interaction with Greg, since Greg could not be live today.
Presentations by you and Vicki. Coming back to this issue of this being a patient safety and caregiver safety issue, can you tell us what you're doing at Texas Medical Center and at MD Anderson to bring these spheres of patient safety quality together with law enforcement on this new area of readiness for these and the threat management?
Well, Chuck has mentioned a presentation about the process for assessing readiness for an active shooter event. We're trying to partner with our law enforcement colleagues to make sure that there's an open channel of communication to make sure that our staff understand everybody in these events. We're moving towards participation in active shooter training with law enforcement so that patients or caregivers who are in one of these events will get the care that they need. I think more importantly, we're trying to provide mass education to people who work in our government about the topic and what their role is and what they can do to prepare for should it take place. And we're trying to use the run, hide, and fight strategy to make sure people are prepared for acting when these events take place. Now, across the Texas Medical Center, we have a number of institutions that face the same sort of challenges, that have the same sort of vulnerabilities as we do at MD Anderson. And one of them is to move into a product where we acquire space and personnel and knowledge and skills to put training for the community as a whole, and have a place where we can integrate with our law enforcement and emergency medical services personnel to make sure that when we practice this, we have a plan in place that most efficiently allows us to not problem at hand, but offer the best care to those who are injured during one of these events.
Great, Greg. Question is, all of us that are doctors and nurses and respiratory therapists and caregivers, the community feels like we would know what to do in an emergency because we have medical training, but the matter is we haven't been trained on casualty management, which is almost like in a combat scenario. It's been a long time since many of us have had any sort of training, the likes of which you do in these programs. Can you give working examples? You and I have had some extensive discussions about what to do when somebody's bleeding, airway, creating the medical lane. Can you go through things that are the specific and tactical detail that such a program to the caregiver side of when a bad event occurs?
So the care that we deliver during one of these events is very different from the type of care we deliver in an ongoing basis in many of our hospitals. Physicians and nurses and other allied health professionals are trained to deliver care in the usual care setting, but we have very little experience in how to provide emergency patients who have been injured in an active shooter event. In fact, just the approach to getting access to these injured is different. This is an active law enforcement environment, and there is a certain amount of direct and indirect threat to the people who are in that environment. And so we have structured programs for training for law enforcement and healthcare providers to work together to understand how to use law enforcement and healthcare providers together to open a medical lane into this very hot environment and go in and move patients from high areas of threat to lower areas of threat where they can get the care they need. The care that's delivered in these very high threat areas is much different than what we would do in a normal medical emergency. We're dealing with opening an airway, stopping external bleeding, and moving the patient as quickly as possible to an area of lower threat, indirect threat area where they can receive more advanced care, and ultimately moving them out of the threat area to a place where they can interface with emergency medical services to be transported to a healthcare environment where they can get definitive care for their injuries.
Greg, you and I have had the conversation about how much more that these issues are. They're growing once you address education. The part that is not made public is how some of these techniques you've just described are not being made public because you don't want to arm bad guys with more ideas on how to harm people. Do you just want to address the fact that with qualified and credentialed caregivers, there's a lot we could learn from the prior where there could have been lives that were saved? Is that a fair statement, and do you want to expand on that?
Well, I think we've learned an awful lot from the events that have taken place thus far in our communities, but much is not known about the care that's provided in those circumstances. Obviously, we don't want to give information to potential active shooters to give them more opportunity to cause harm in our institutions, but we can work together as a healthcare community and law enforcement community to develop strategies for effectively caring for injured people in these circumstances. We have translated the tactical casualty care program that's used in war theater for dealing with combat casualties. That's been translated into tactical emergency casualty care in civilian world for dealing with these active shooter events. We've taken some of the skill sets and the strategies and moved them from combat into these very high threat environments with best practices and known interventions that can save lives in order to improve outcomes.
Fantastic. Vicki, thank you for a fabulous presentation, and I think all of us are drawn to your slide, you're next to the last, on the core functions of a threat management unit. And I think the area of active shooter is dramatic. It isn't in the naturally thought to wheelhouse of our quality and safety leaders, and yet when you talk about threat management, you're talking about broader threats that include but are not limited to active shooter events. Do you just want to go through some of the other threats that are safety and quality threats to an organization that you cover with this kind of an approach?
Absolutely. We look at stalking. We look at threats. We've had physicians who have had patients who have become fixated on them. We had one patient in particular who became so fixated on her psychiatrist that this person followed the psychiatrist all around the country. And when they were arrested, as soon as they got out on bail, they began to reoffend and went to the penitentiary after having their probation revoked, used all mental health treatment because they felt like nothing was wrong, and served out their sentence with without getting the extra credit good time in order to continue to talk this person after their release. So these kinds of events, very, very long duration. The domestic violence, we've talked about that. We have talked about some patients on the anniversary of the death of a loved one will revisit that, and we look at those milestones, we look at those anniversaries as potential threat situations. We look at the terroristic threat when we look at software hospitals are. We have to be prepared for those cadence, and although this training, we won't give away all of our law enforcement secrets. I think it's been widely reported that in these types of catastrophic events, especially if there's a terrorism nexus, that secondary devices and the targeting of first responders is something that we have to be very cognizant of. And so if we can train people to go to safe places and to know that those places are safe, where we can have sweeps of bomb dogs, we can have some additional layers of protection, and we prepare for that in advance, then our response is going to be greatly enhanced and we're going to save more lives. And that's the key to having active shooter training, and to think through, because you respond how you train.
Perfect segue to my next question. I know that Dr. Botz and I know you for immersive simulation of really putting people in this scenario. And I, as a pilot, gone through a bunch of simulation training to fly jets and sophisticated airplanes. These simulation experiences are so real, even though to the naked eye as somewhat artificial. When you create a scenario and the person feels the stress and tension, it totally changes the dynamic, and you understand that without the training, really, you really can't respond as quickly or as properly. Do you want to kind of address how you're championing the cause for immersive simulation and how you would use that to work together with caregivers and law enforcement?
Well, immersive simulation is probably the crown jewel of all training. It serves multiple purposes. Not only does it help the person learn how they will respond as an individual to stress, to a particular scenario, it also serves as stress inoculation, and we learn from that. Imagine a physician your first day going into the emergency department, and the first time that ambulance rolls in, your heart is racing, you're not thinking as clearly as you should, and if we can, through training and exposure and understanding, it's more than just reading it in a book. It's more than getting a brochure. It's unfortunately attending a webinar. It is immersing yourself in that situation, seeing how you're going to respond, and being able to execute under high-stress situations. We do that with our police officers so that they can respond appropriately. It's what you do with your surgeons and your residents and your nurses. We teach, and that's why it is so critical that we be able to respond in these kinds of catastrophic events. But coupled with that training for that rare event is how to recognize potential threats and how we can perhaps prevent them.
Great stick. Now I'm going to ask Dr. Botz and Vicki to be on the speakerphone, and I know that our audio will be because they're on speaker, and we'll accept that in order for them to play off of each other on just some questions that they can answer and build on together. We know with the 9/11 event that enormous gaps in coordination and enormous gaps in communication that really are identified, and as well in New York City, that people have now sought to close. Can you address this issue of communication and coordination amongst the law enforcement, first responders, caregivers, administrators of hospitals, what we've learned, and might be a starting point for an organization that's just on the beginning of the curve to put together their threat management system. And we'll ask you maybe, Greg, to go first, and then Vicki, and play off of each other because we've got plenty of time. Feel free to comment on each other's answers.
Absolutely, Chuck. I think the learning from those events regarding communication was crucial. We work in silos, and we have our own language that the insider with, but it doesn't necessarily translate to good communication across interfaces with organizations. Sharing knowledge and sharing information has been a challenge in large organizations for years. In healthcare, we have a vernacular. We have a set of terms that we use for things, but people outside our realm don't understand. And I think one of the things we've learned from the incident command system at a national and local level is to use plain language to communicate effectively with each other so that everyone involved in the circumstance is on the same page with the same information.
I couldn't agree more. The plain language is critical. And when we get together in these exercises and we work together as a team, we can identify those information and communication gaps. It's also an opportunity for us to network with our partners. You may not know who the key players are in the hospital. You may not be able to put a name with a face. You may not know who is in charge of medical triage in a catastrophic event only through a name. Now you can put a face with that person. And we all speak that common language. We all start pulling in the same direction. And we can work out any differences or any concerns or any critical infrastructure gaps in these highly simulated exercises.
Fantastic. One thing that we have realized as we look at training and education through our Care University programs is to put a sharp edge on and define what we call high-impact care hazards. And there are some that are highly frequent and highly impactful or highly severe, and there are the low-frequency, high-impact. So an active shooter would be low-frequency, we hope, very high-impact. What about the much more frequent but lesser impactful threats that you all address that can be targeted as well? Maybe, less dramatic and less impactful, but threats that we need to be aware of as we put a threat management system together, where there may be things that happen a lot more frequently. They're not as bad, but in aggregate for a year, they're not good for caregivers or patients. And I think some of these are breaking policies that we know that are really important policies, but they're not adhered to all the time, and then we run into issues there. We know that fear is a major component in terms of reporting, and you mentioned, Vicki, that there's likely a gross underreporting of things that are going on, especially with bullying and abuse of power and that kind of thing that can really make things tense. What are the highly frequent, not too severe, but could then show up as a severe event later on that should be part of a threat management system?
Well, we have seen inappropriate relationships. We've seen sexual harassment escalate. We clearly stalking events, harassment events, just interpersonal conflict that has grown and escalated over time. The sooner that you intervene in those high-frequency, low-threat situations and get them recognized and get to the root cause, you have a better opportunity than letting a frustration build and build and build until there's an explosive outcome. A fist fight in the parking lot may seem relatively minor when we're talking about an active shooter, but people who are frustrated, who feel that they are being bullied in the workplace or that they have no power source for their anger and frustration, can resort to violent means to get even. We don't want those events to escalate.
The issue of the overtaxed emergency department or overtaxed services where caregivers appear to be or may really be abusive by their lack of attention to patients' help with pain or problems or the severity of their emergency, and the abuse of power or abuse of power by patients can lead to these abusive events in retaliation, or just because, as you say, Vicki, they feel like they have no control, they're suffering, people don't care, and they're being cruel.
I think if we reflect on our own experiences in healthcare, identify people whose behavior was outside the norm but was accepted because of who they were or the role that they play, and oftentimes we minimize the potential impact of those behaviors until an event occurs. And what I've learned in working with my law enforcement colleagues and with our threat management group in the hospital is that those are the opportunities to identify and report before the event takes place, because that's when it's easiest to do and when the most resources are available. And I think the reluctance on the part of healthcare providers to act in that way because of professional or academic gradients between practitioners is a particular hazard in our environment. We all know that we work in a very stressful environment. In fact, I think since I started working in medicine, it's much more acute and much more stressful than I remember. And in those circumstances where healthcare providers may seem overwhelmed with the stress or the acuity of our patients, we tend to take shortcuts, and perhaps we pay less attention to the patient's needs by trying to protect ourselves, our own emotional health, that we're in fact allowing some harm to happen to our patients. For instance, we may not be as responsive to the patient's request for pain medication because all of our patients are asking for this, and maybe that symptom pales in comparison to the other problems that are going on in the patients we're caring for. And that patient may not get the pain management they need at the right time. Those are the sort of behaviors that can creep into our practice that can be significant patient safety issues to our community.
And also, I might add that I don't think you can have a visit to the emergency department in any hospital across the nation and not see high drama playing out every single day. That was the patients coming in who are themselves in a high state of anxiety, a high state of arousal and frustration and fear. People who walk in the door, they're afraid. They're afraid for their loved ones. They're afraid for themselves. And the nurses have a job to do. They have to triage, and the patients not knowing what's going on behind the curtain, so to speak, they think that they're being ignored, or that they're not important and they're not valued, or that their situation isn't there, and that frustration builds and they start to demand action. And so there's a great deal of potential for violence, and patients who are walking in or family members who are being advocates, strong advocates for their loved one, to introduce a violent component to the emergency department.
Recently in the Houston area, there was an event in an emergency room at a local hospital, a community hospital, where a patient was requiring full life support, and the care team thought the patient might fulfill the criteria for brain death. And the patient's father went into the room, and on hearing this information, didn't believe and didn't trust the caregivers, and in fact escalated the circumstance by pulling a weapon and creating a hostage situation. Very difficult situation to manage.
The last question, and I know you've got some wonderful colleagues that'll help answer questions from our audience. However, Greg, the issue that is of critical importance to us in patient safety, the caregiver that is singled out and bullied through cybercrime and through the web, or a release of personnel files, or a host of other ways that organizations kind of treat the bad apple to try to make that the problem is not a systems issue, but it's a bad apple. So they have a public hanging of that person to try to protect them financially, and unfortunately that backfires sometimes into suicide by nurses or terrible events that occur in their families because they've out. Vicki, do you want to address this issue of the employee and and this being? And we know that perhaps this is a mixed issue, or you could separate it into two. The second one that we see is a healthcare organization is taken over by new management that are highly focused on financial issues, not adhering to the policies that the caregivers see as being harmful to patients. Safety problems start to increase, and then when the caregivers make the reports, they're sold out and bullied into submission or leave the organization because of financial reasons.
Bullying of any type is probably the number one reason given by active shooters or those intent on a violent action. They're defending themselves. They feel justified in taking violence for the reason that they were treated unfairly, that someone more powerful was exerting their power in an inappropriate manner. So those are definitely, we've seen patients who've had financial difficulties blame the financial analyst who's just making the cold call, just making the phone call, trying to make some arrangements, and they become the fixation or the target. We've all seen where hospital policies are met with frustration by the caregivers who feel that they are running counter to a patient's best care. And those types of issues can be mediated. They can be, if the aggrieved person can be heard, if their complaints can be properly vetted, if they can have a feel that they are being valued as a human being with their contributions, you can mitigate that threat extremely effectively. It's when we push people aside, say that they don't matter, that this is the institution's larger than an individual, or that person isn't properly cared for as a human being or valued as a human being, then we see the threat potential multiply.
So is it fair to say that if there was an anonymous reporting system with no identity where people could speak out regarding their frustrations and hope that then their action would be taken, that an early warning system focused on bullying might be of value?
Absolutely. But a key here, too, is for the person to know that they've been heard and to provide some feedback mechanism. If they're anonymous, it's very difficult to provide direct feedback. But if there was some transparency in the organization where concerns that are raised could be put on a window for others to view and comment and to help resolve, and I think that goes a long way. Again, establishing that communication, but definitely an anonymous reporting system for someone who feels as though they are less powerful in the institution than another person. We've had situations where some powerful people in the institution have exerted their influence on less powerful people, and walking away from the job or losing good, valuable employees is the smallest amount of repercussion that we can have. We've had lawsuits that have been generated. Failing that, we've seen people try to take the law into their own hands and gain retribution or sabotage an individual. All those types of acts are detrimental to organizational health, and this is clearly an organizational health model that we're advocating.
Well, that is terrific. What a great thing to make is that it's an organizational health and a threat, early warning and early intervention threat model. We want to thank both of you for terrific presentations and great answers to the questions. And we know we have some of your colleagues able to answer some of the questions that will come from our audience. Thank you so much, both of you, for great presentations. So we'd like to now introduce, and we have for the last portion of our webinar, Chief William Adcox
He is the Chief of Police and CSO, Chief Security Officer for the University of Texas MD Anderson Center at the University of Texas Health Science Center. He's got 37 years of history and experience in municipal and campus policing. Serves as the chief of police, as I stated. Has numerous awards for administrative excellence, such as one in Security Magazine is one of the most influential people in security in 2013, and received the prestigious 2015 Lindbergh Bell Distinguished Program Award. And we'd just like to ask Chief Adcox if there's anything that he would like to affirm or add. And I've got two questions from our audience that I'll tee up to both of you. Chief?
Yes, Charles, thank you very much. It's an honor to participate today. I think the speakers did an excellent job. The only thing I would add is that if you work your program right, it has to be multidisciplinary, and it has to have the executive support. So if you start with the premise of a unified risk approach, and you look at bringing all these individuals together and find out how you can develop those communication protocols so that everybody's on board. Otherwise, you still have those transition gaps, and that's where people get hurt. And what we did here at MD Anderson is that as we were going around and working and talking to the executives, the C-suite, if you will, we actually got approval, and the president, the CEO, started what was called an all hazards risk leadership council. So you got 25 of the highest level individuals at different mission critical areas that sit on this particular board, and they'll meet on a regular basis. And so therefore they're looking at developing and putting together the risk profile, or the risk, you guess you go like a risk inventory. And around that is how do we all come together. So underneath that you have your multidisciplinary approach, and here we call it a behavioral intervention team. And this is where that you can get the magnitude of how do you extend that prevention opportunity. So what is it that you can do as a whole, not just a department, whether it's security, whether it's clinical care department, it's after-hours administrators. You bring in everybody together to say, well, what is it that we can do together to stop these things from happening to begin with? And it's a very holistic approach. But again, to me, it's about how do you deliver it through the executives, because without the executive support, it's nearly impossible to get something done. And that's the only thing I would really add, Charles.
Fantastic. What a great comment. And I think this unified risk approach and really getting from the bedside to the boardroom is so critical to get administrative, and I think board leaders as well would be important. Thank you so much. I'm just going to rattle off 2 or 3 questions and have you all answer them in whatever order you like. But I think, Chief, you opened up this issue, of threat. Of the unified threat approach. One of our viewers, John Fisher, asked the question or stated, "I'm looking for a hospital-oriented threat assessment form. Is there a link or a resource that we could tackle?" And I'm going to throw the other question in here, Alice, regarding the run, hide, fight approach. And the viewer Heather Borinsky asks, are you aware of ALICE training, which is alert, lockdown, inform, counter, and evacuate? And then the third question was regarding ambulatory environments and physicians' offices when you don't have security. So the first question is, are there links to resources for hospital-oriented threat? The second one is ALICE. And then the third one is, what about ambulatory environments where we don't have a great security infrastructure?
Well, this is Bill Adcox again. I would say that there are several organizations that are very, very helpful. The one that really comes to mind is what's called ATAP, the Association of Threat Assessment Professionals, and they have a lot of resources, and they work in all the different arenas, whether it's the corporate America, whether it's a hospital, whether it's an educational institution, a high school. They have different expertise, and they're really good. ALICE is an excellent program. There are many programs out there, whether it's the run, hide, or fight. There's just different ways that you can approach it. So I would recommend that if someone particularly likes the ALICE approach and they want to do it, it's great. If they like a different approach, then that's fantastic. specifically to hospitals, there's some different things that are in play because you might have patients that and their family members, and because of the stress and people being distraught. So what we utilize here is the Crisis Prevention Institute has a specific training in which you teach folks on de-escalation and then also the proper ways in which to restrain an individual like a particular patient. And so to me, you have to have multiple approaches that you put together under the multidisciplinary team in order to be successful. And I think that's really where you're going to be your key success, because you really want your security department to be your first responders to a patient that's getting out of hand. When if you could have had de-escalation in place and then had the right triage protocols in place before you bring in your security, then you have more layers in which to protect the institution, protect the patients, and have a much more positive outcome.
When you're talking about the ambulatory clinics, we have a regional clinic network here with MD Anderson and UT Health, and the critical component there is education and training of those staff members, how to recognize behaviors of concern, who to report to, how to stay connected, and how to be connected with your police department or security team. Threat assessment of those problematic patients, employees, or outside influences that may threaten patient or staff safety have to be reported early. And your threat management team must be engaged at the point that the threat is first recognized so that we can get ahead of a catastrophic event. Intervention cannot occur without reporting. So we give our teams the tools, we tell them what to look for, and we tell them how to report it, and then we have an extremely responsive group that goes in and helps evaluate and applies an intervention strategy that is most likely to manage that situation, manage that threat for a positive outcome.
Well, fantastic. I'm going to ask one question, and then I'm going to take a couple of minutes at the end. It turns out that the Joint Commission on Accreditation has just posted a national patient safety goal that this audience, actually our national audience that's listening to this webinar, had a role in helping bring forth to help protect children. So it's not only a celebration time for us, but also a call to action to have them support this online. So what I'm going to do is just shift gears for a moment. But while our webinar was going on, this Joint Commission issue was just posted on the web, and I'm going to scroll down and you'll see it on my machine. And this is regarding the National Patient Safety Goal for pediatric imaging. And this audience had an enormous impact on prior polls that we did. We poll our audiences nationally, and we were able to poll this audience regarding this issue, which was this was slide 13 that I showed earlier. Kyle will update the slides. I noticed the formatting changed a little bit when it was converted to WebEx, and so we'll make some fixes for our audience and we'll update them. These were slides 13 and 14, which we put up, which addressed this a call. It was a call to action nationally and globally, in fact, because we're working with the World Health Organization on protecting children from overexposure to ionizing radiation. And I just want to congratulate our audience that are still on. This was just posted on the Joint Commission website, which is proposing between now, today's date, and March 31st that a national patient safety goal on pediatric imaging be developed. And there's a way to submit your comments on an online survey or online form, which we will send out to all of you. We have a network that sometimes we invite as many as 80,000 to. Kyle will do it to the entire group. And then if you click on that, this is the proposed national patient safety goal. And in respect to our two speakers from the security area, we won't read this and take your last minute to comment, but I just wanted our audience to see that the national patient safety goal that we all worked really hard to help put through has actually been approved by the board, but out for review. And we need to have everyone, consumers, patients, patient advocates, quality safety leaders, everyone, to submit their support for this to protect children from the overuse of CT. There's no debate on the science, so it's just a matter of habit. That Warren Buffett said the chains of habit are too light to be felt until they're too heavy to break. It's habit that we overdo CT and that we're using adult protocols and not using the best practices for protocols and still getting good images. So sorry to interrupt the two of you, Bill and Vicki, but this just happened while our webinar was underway. So what I'd like to do is I'll go back now to each of you and ask you if you have some final thoughts. And I guess my feeling is I think there's an enormous opportunity for groups to get together and work together to create perhaps some national summit programs and some online training to be able to get these great best practices you've been developing and working on out to the national community. Is it reasonable to think that we could bring people together for some national meetings and then some online train-the-trainer programs to work together as teams? Short question is it worthwhile to get caregivers, patient safety officers, first responders, law enforcement together to perhaps practice immersive simulation and go home and learn how to teach it? I'll turn both to you, Bill, and to Vicki.
Absolutely. That's going to be the key to success. It's not just teaching people what to do in an active shooter situation. The important piece of this is to teach them how to recognize behaviors of concern, what to do about it, and how to activate and develop a robust threat management program within their own institution. The key here is prevention, and we can't emphasize that enough.
No, I dovetail on that. I agree 100%. If we don't train and we don't have a common language and we don't train together and we don't understand how we can extend that prevention opportunity, we're just not going to be as successful.
Well, thank you so very much. And we're going to go through the slides. I saw some formatting tweaks, Vicki, on some of yours that were no fault of yours. They were just a conversion for WebEx, which we'll fix. And we'll add the elements of this national patient safety goal. We really feel so blessed, and we're so thankful. A lot of answered prayers to get this national patient safety goal through. Arlene, would you like to close us? Someone who really is so knowledgeable on the bullying in healthcare and really kind of really focused on this topic, which I think was right up your alley. Arlene, would you close us? And we'll have the speaker stay on so we can do a quick process improvement loop. And we'll close after Arlene. Arlene?
First of all, great news on the CT imaging. I'm very happy about that. Prevention, and that is the key word. I don't know if everybody knows, workplace bullying is legal in every single state. There's no law against it unless you're in a federally protected category. So I would like the people on the webinar to really look at that, to make that a system of educating, having anti-bullying education and policies in every facility, every workplace. So thank you very much for being here, and thank you for your presentation. It was great.
Well, thank you, and thank you all for your great support through the polls and your great grassroots support of Dr. Swensen and this wonderful team on patient safety for children. And we'll be back to you to invite you and give you more detail on how to respond. And if our speakers could just stay on. So this closes our webinar. God bless you all. Thank you so very much.